Question 1. A postoperative patient suddenly becomes restless, tachycardic, and hypotensive. What is your first action? A. Increase the intravenous IV fluid rate. B. Perform a focused assessment including airway, breathing, circulation, ABC. C. Administer PRN opioid for pain. D. Call the surgeon immediately. Answer. B. Perform a focused assessment including airway, breathing, circulation, ABC. Rationale. The priority in sudden deterioration is rapid assessment of ABCs to identify life-threatening causes, for example, hemorrhage, hypoxia. Increasing IV fluids, A, may be appropriate after assessing for hypovolemia, but doing so without assessment risks masking or worsening conditions. Administering opioid, C, could depress respiratory drive if respiratory compromise exists and is inappropriate before assessment. Calling the surgeon, D, may be needed, but assessment guides what to report and immediate interventions. Assessment comes first. Question 2. A patient with shortness of breath has oxygen saturation 88% on room air and respiratory rate 30. What is the most appropriate immediate intervention? A. Obtain an arterial blood gas, ABG. B. Apply supplemental oxygen and reassess respiratory status. C. Prepare for intubation. D. Encourage pursed lip breathing. Answer. B. Apply supplemental oxygen and reassess respiratory status. Rationale. Hypoxemia, SpO2 88%. Requires immediate supplemental oxygen and reassessment. ABG, A, is useful but not before stabilizing oxygenation. Intubation, C, is for impending respiratory failure after assessment and trial of oxygen or other supports. Pursed lip breathing, D, may help COPD patients, but is not an immediate intervention for acute hypoxemia without assessment. Question 3. When prioritizing care for 4 patients, which patient should be seen first? A postoperative day, one with stable vitals, a chest pain patient with new ST changes, a confused patient due to low sodium, or a patient due for discharge teaching. A. Postoperative day, one stable patient. B. Chest pain patient with new ST changes. C. Confused patient with hyponatremia. D. Discharge teaching patient. Answer. B. Chest pain patient with new ST changes. Rationale. New ST changes suggest acute myocardial ischemia, time-sensitive and highest priority. The confused hyponatremic patient, C, is urgent but less immediately life-threatening compared to ongoing cardiac ischemia. Postoperative stable, A, and discharge teaching, D, are lower priority. Prioritization follows threat to airway or circulation or critical time-sensitive conditions. Question 4. A nurse suspects a medication error, but the patient is stable. What should the nurse do first? A. Document that the patient received the medication and forget the rest. B. Report the error to the nurse manager and file an incident report immediately. C. Assess the patient for adverse effects and notify the prescriber as needed. D. Call the pharmacist to complain about the unit's workflow. Answer. C. Assess the patient for adverse effects and notify the prescriber as needed. Rationale. Patient assessment and safety come first. After ensuring patient stability and addressing clinical needs, the nurse must notify the prescriber and follow facility policy, including incident reporting. Simply documenting and ignoring, A, is unsafe and unethical. Reporting to manager and filing incident report, B, is required, but after initial assessment and any necessary interventions. Complaining to pharmacist, D, is unprofessional and not first action. Question 5. A patient refuses a blood transfusion for religious reasons. What is the correct nursing response? A. Respect the patient's decision and document refusal after ensuring informed refusal. B. Insist transfusion is necessary and proceed for best outcome. C. Contact family and proceed if family consents. D. Administer blood anyway if condition worsens. Answer. A. Respect the patient's decision and document refusal after ensuring informed refusal. Rationale. Respect for autonomy requires honoring informed refusals. Nurse should ensure the patient understands risks or benefits, document refusal, notify the provider, and explore alternatives. Forcing B and D Violates ethics and law. Family consent C. Does not override competent adult refusal. Question 6. In clinical reasoning, the nurse uses pattern recognition to identify a likely diagnosis. What is a key limitation of this approach? A. It always provides the correct diagnosis. B. It may lead to premature closure and missed atypical presentations. C. It eliminates the need for assessment data. D. It is never useful in emergency situations. Answer. B. It may lead to premature closure and missed atypical presentations. Rationale. Pattern recognition is efficient but risks premature closure, accepting a diagnosis too early without full data. It does not always yield correct diagnoses, a false. It does not eliminate the need for assessment, C. It can be useful in emergencies, D. False, when rapid recognition is needed. Awareness of limitations prompts verification. Question 7. A patient with delirium is pulling out IV lines. What is the best immediate action? A. Physically restrain the patient to prevent line removal. B. Conduct a rapid assessment to identify reversible causes and ensure safety. C. Sedate the patient to prevent further disturbances. D. Ignore until the patient calms down. Answer. B. Conduct a rapid assessment to identify reversible causes and ensure safety. Rationale. Delirium is often reversible, for example, hypoxia, pain, medication effects. Rapid assessment to identify cause and ensure safety is priority. Restraints, A, may be considered only after alternatives tried and per policy, and sedation, C, risks harm without assessment. Ignoring, D, is unsafe. Interventions should be least restrictive and treat underlying cause. Question 8. A newly licensed nurse is unsure about delegating a task. What should they do? A. Delegate it regardless to manage workload. B. Consult the Nurse Practice Act, facility policy, and the RN scope of practice before delegating. C. Assign it to the least experienced staff to teach them. D. Refuse to give any tasks to others. Answer. B. Consult the Nurse Practice Act, facility policy, and the RN scope of practice before delegating. Rationale. Safe delegation requires understanding legal scope and agency policy. Delegation decisions must consider staff competency, patient stability, and regulatory guidance. Delegating without checking, A, risks unsafe care. Assigning to inexperienced, C, without assessment is unsafe. Refusing all delegation, D, is impractical and may harm patient care. Question 9. A patient's bedside monitor alarm is silenced by a colleague. What is the nurse's best response? A. Leave it silenced if patient seems fine. B. Re-enable the alarm and assess the patient and rationale for previous silence. C. Remove the monitor if the patient is stable. D. Report the colleague immediately to administration. Answer. B. Re-enable the alarm and assess the patient and rationale for previous silence. Rationale. Alarms are safety devices. Silencing requires justification. The nurse should assess the patient, determine why alarm was silenced, and re-enable if no valid reason. Leaving it silenced, A, risks missing deterioration. Removing monitor, C, removes safety without reason. Immediate reporting, D, may be needed if unsafe practice persists, but first assess and correct current risk. Question 10. A patient with new neurological deficit after stroke is scheduled for discharge. What should the nurse prioritize? A. Discharge is scheduled to free bed space. B. Reassess neurological status, notify the provider, and delay discharge if deterioration is present. C. Provide routine discharge teaching and encourage follow-up. D. Arrange outpatient physical therapy only. Answer. B. Reassess neurological status, notify the provider, and delay discharge if deterioration is present. Rationale. New deficits suggest clinical change. Reassessment and provider notification are required. Discharging without evaluation, A, risks harm. Routine teaching, C, and arranging therapy, D, are important, but secondary if patient is deteriorating. Clinical judgment requires reassessment when new signs appear. Question 11. Which question best demonstrates using the clinical judgment model to decide nursing priorities? A. What task can be completed fastest? B. Which patient has the most immediate threat to airway, breathing, or circulation? C. Which patient sounds more agreeable? D. Who has the most paperwork? Answer. B. Which patient has the most immediate threat to airway, breathing, or circulation? Rationale. Clinical judgment prioritizes life-threatening conditions, ABC. Speed A, agreeableness C, or paperwork D, are not clinically sound prioritization criteria. This reflects application of urgency and safety in decision-making. Question 12. A nurse must decide between two interventions supported by conflicting evidence. What is the best approach? A. Choose the intervention that is easiest to perform. B. Analyze the quality of the evidence, consult guidelines, and consider patient values. C. Always follow the older, established practice. D. Defer decision to a non-clinical administrator. Answer. B. Analyze the quality of the evidence, consult guidelines, and consider patient values. Rationale. Evidence-based practice requires appraisal of evidence quality, clinical guidelines, and patient preferences to make informed decisions. Choosing for ease A, or defaulting to older practice C, may be suboptimal. Deferring to non-clinical admin D, ignores clinical responsibility. Question 13. A patient with sepsis has low urine output. What is the nurse's next best step? A. Increase oral fluids. B. Assess fluid status, review intake or output, and notify provider. Consider fluid bolus per protocol. C. Document and wait for labs. D. Restrict fluids immediately. Answer. B. Assess fluid status, review intake or output, and notify provider. Consider fluid bolus per protocol. Rationale. Oliguria in sepsis suggests hypoperfusion. Nurse should assess volume status and notify provider. Fluid bolus per sepsis protocol may be indicated. Increasing oral fluids, A, is not appropriate for an acutely ill or septic patient who may be NPO. Waiting C, delays treatment. Restricting fluids D, could worsen hypoperfusion unless fluid overload is confirmed. Question 14. When communicating with a multidisciplinary team about a patient deteriorating on the unit, which statement shows effective advocacy? A. I think the patient's fine, we can wait. B. The patient's respiratory rate increased to 34 and SpO2 is 86%. I recommend rapid response evaluation. C. I'll handle it myself. No need to involve others. D. This is not my problem. Check with the doctor. Answer. B. The patient's respiratory rate increased to 34 and SpO2 is 86%. I recommend rapid response evaluation. Rationale, clear, objective data, and specific recommendation advocate for patient safety and prompt action. Minimizing A, hoarding responsibility, C, or deflecting D, are poor communication and risk patient harm. Effective advocacy includes concise SBR-style communication. Question 15. A nurse must decide whether to override a pharmacy-verified allergy alert for a critical antibiotic. What should guide the decision? A. The nurse's personal judgment without consulting others. B. Verification of the allergy history, assessment of reaction severity, consultation with prescriber or pharmacy, and documentation of informed risk. C. Ignore the alert and administer because the infection is severe. D. Cancel all antibiotics permanently. Answer. B. Verification of the allergy history, assessment of reaction severity, consultation with prescriber or pharmacy, and documentation of informed risk. Rationale. Allergy alerts require careful verification. True anaphylaxis history differs from minor reactions. Consultation and informed risk or consent are essential. Acting alone, A, or ignoring alert, C, risks severe reactions. Canceling antibiotics, D, is inappropriate. Question 16. A patient asks about a treatment that is not supported by current evidence. How should the nurse respond? A. Dismiss the patient's question and refuse to discuss. B. Explain current evidence, discuss risks/benefits, and explore patient values and alternatives. C. Encourage the improvement treatment because patient requested it. D. Tell the patient the evidence doesn't matter. Answer. B. Explain current evidence, discuss risks or benefits, and explore patient values and alternatives. Rationale. Patient-centered care requires honest, evidence-based education and shared decision-making. Dismissing A. Encouraging and proven therapies, C, or devaluing evidence, D, are unethical. Discussing alternatives and respecting values supports informed consent. Question 17. A medication order seems ambiguous. What is the safest action? A. Administer the medication as you interpret the order. B. Clarify the order with the prescriber before administration. C. Have a colleague guess the intended dose. D. Delay medication indefinitely without notification. Answer. B. Clarify the order with the prescriber before administration. Rationale. Ambiguous orders must be clarified to prevent medication errors. Administering based on interpretation, A, or guessing, C, risks harm. Indefinite delay without notification, D, risks mistherapy. Clarify promptly. Question 18. A nurse notices a potential ethical conflict between patient confidentiality and public safety, reportable infectious disease. What is the correct action? A. Maintain confidentiality regardless of public health laws. B. Report to public health authorities as required by law and inform the patient per policy. C. Post about the case on social media to warn others. D. Ignore the requirement and ask the patient to handle reporting. Answer. B. Report to public health authorities as required by law and inform the patient per policy. Rationale. Public health reporting requirements override confidentiality for certain conditions. Nurse must comply while following policy for patient notification. Maintaining confidentiality. A. Conflicts with mandated reporting. Social media, C, is breach of ethics and law. Asking patient to handle it, D, abdicates professional duty. Question 19. A novice nurse is making decisions under time pressure and seems to rely only on textbook algorithms. What mentoring strategy best supports development of clinical judgment? A. Criticize them for not knowing everything. B. Use case-based questioning, reflective debrief, and encourage pattern recognition with deliberate practice. C. Remove them from patient care permanently. D. Tell them to memorize more facts. Answer. B. Use case-based questioning, reflective debrief, and encourage pattern recognition with deliberate practice. Rationale. Mentoring that includes reflection, guided questioning, and deliberate practice builds clinical judgment and adaptive expertise. Criticism, A, removal, C, or rote memorization, D, are unhelpful. Teaching should develop reasoning and decision-making. Question 20. During evaluation, a patient's prescribed intervention fails. What is the nurse's best next step? A. Continue the plan regardless. B. Reassess patient, collect data on why it failed, consult team, and modify the plan based on findings. C. Blame the patient for noncompliance. D. Discontinue all interventions permanently. Answer. B. Reassess patient, collect data on why it failed, consult team, and modify the plan based on findings. Rationale. Evaluation requires determining effectiveness. Failure necessitates reassessment, data collection, team input, and plan revision. Continuing unchanged, A, or blaming, C, is unprofessional. Discontinuing all interventions, D, may harm patient. Clinical judgment is iterative. Assess, plan, implement, evaluate, revise. Question 21. A prima gravida at 39 weeks in active labor with baseline fetal heart rate 140 BPM, frequent variable decelerations, but occasional late decelerations. What is your immediate action? A. Continue routine monitoring and encourage position changes. B. Initiate intrauterine resuscitation. Reposition mother. Give IV bolus, oxygen, and stop oxytocin if running. C. Prepare for immediate assisted vaginal delivery without other interventions. D. Apply internal fetal scalp electrode to confirm baseline before acting. Answer. B. Initiate intrauterine resuscitation. Reposition mother. Give IV bolus, oxygen, and stop oxytocin if running. Rationale. Immediate intrauterine resuscitation addresses reversible causes of late or variable decelerations, uteroplacental insufficiency, cord compression, or hypotension. Position change left lateral. IV fluid bolus to improve maternal perfusion, oxygen for mother, and stopping uterotonics, reduce fetal stress. Option A delays treatment of concerning pattern. Option C is premature. Assisted delivery is only indicated if resuscitation fails and delivery is imminent or indicated. Option D may help confirm tracing but delays treatment. Management should begin based on current concerning decelerations. Question 22. A 28-year-old G2P1 at 32 weeks presents with new onset hypertension 150/98 millimeters of mercury and 3+ proteinuria. What is the next best step in risk stratification and immediate management? A. Reassure and schedule routine prenatal follow-up in 2 weeks. B. Admit for maternal observation, labs CBC, CMP, urine output monitoring, and fetal assessment, including NST and ultrasound. C. Start oral antihypertensives at home and instruct patient to rest. D. Arrange immediate induction of labor. Answer. B. Admit for maternal observation, labs CBC, CMP, urine output monitoring, and fetal assessment, including NST and ultrasound. Rationale. New severe preeclampsia features at 32 weeks require inpatient evaluation for maternal or fetal status. Labs, platelets, liver enzymes, creatinine, urine output, and fetal testing, NST, growth fluid. Option A risks missing deterioration. Option C may eventually be appropriate, but outpatient RX alone is insufficient given proteinuria and BP severity. Option D induction is not indicated right away at 32 weeks unless maternal or fetal compromise is confirmed. Admission allows escalation and planning, steroids, magnesium if indicated. Question 23. A laboring woman with epidural anesthesia reports decreased urge to push and descent has stalled. Fetal heart rate is reassuring. What is your best midwifery action? A. Encourage continued passive descent for another 4 hours. B. Assess effectiveness or level of epidural, bladder fullness, maternal positioning, and consider assisted second-stage delivery if no improvement. C. Immediately discontinue epidural and proceed to general anesthesia. D. Begin oxytocin augmentation to speed pushing. Answer. B. Assess effectiveness or level of epidural, bladder fullness, maternal positioning, and consider assisted second-stage delivery if no improvement. Rationale. Epidural can reduce bearing down. Assessment of block level, bladder distension, common cause of arrest, and maternal position, upright or side lying, may improve descent. If no change in maternal exhaustion or prolonged second stage, assisted vaginal delivery, vacuum/forceps as per scope, may be appropriate. Option A risks maternal fatigue and fetal compromise. Option C, discontinue epidural and general anesthesia, is unnecessary and unsafe. Option D, oxytocin, is not indicated in second stage absent uterine inertia. Augmentation targets contractions rather than pushing effectiveness. Question 24. During vaginal birth, the shoulder becomes impacted after delivery of the head, shoulder dystocia. Which action should you perform first? A. Apply suprapubic pressure and attempt McRoberts maneuver. B. Perform episiotomy and apply fundal pressure. C. Place mother in lithotomy and await obstetrician. D. Immediately perform Rubin maneuver without maternal repositioning. Answer. B. Apply suprapubic pressure and attempt McRoberts maneuver. Rationale. Evidence-based immediate maneuvers for shoulder dystocia are McRoberts, hyperflex hips to chest, and suprapubic pressure to dislodge the anterior shoulder. These are first line and can be performed quickly. Option A is partly correct, but order in many protocols. McRoberts plus suprapubic pressure together. I listed both actions in B to reflect simultaneous maneuvers. Episiotomy may facilitate instruments, but not relieve dystocia itself. Fundal pressure is contraindicated, may worsen. Option C delays urgent action. Option D, Rubin maneuver, is a subsequent internal maneuver if initial external maneuvers fail. Don't skip to internal without attempting McRoberts or suprapubic. Question 25. A woman in third stage of labor has heavy vaginal bleeding and a boggy fundus despite uterine massage. What is your immediate next step? A. Continue massage only and recheck in 10 minutes. B. Check bladder for distension. Give uterotonic, oxytocin, bolus, or IV infusion, and assess for lacerations. C. Start broad-spectrum antibiotics. D. Place uterine packing and send to or immediately. Answer. B. Check bladder for distension. Give uterotonic, oxytocin, bolus, or IV infusion, and assess for lacerations. Rationale. A boggy fundus suggests uterine atony, a leading cause of postpartum hemorrhage. Immediate steps. Uterine massage. Ensure bladder empty. Distension can prevent contraction. Give uterotonics, oxytocin bolus, then infusion, and evaluate for retained tissue or lacerations. Option A. Delays critical therapy. Option C. Antibiotics is irrelevant in acute hemorrhage. Option D. Packing / or may be needed for refractory hemorrhage, but only after initial uterotonic measures and assessment. Question 26. A newborn at 39 weeks is born limp with HR 60 BPM, weak respiratory effort, and poor tone. What is your immediate neonatal action? A. Delay resuscitation and call pediatric team while drying the infant. B. Begin immediate positive pressure ventilation (PPV) with airway positioning and warming and prepare chest compressions if HR remains less than 60. C. Apply CPAP only and observe for improvement. D. Suction vigorously and then place under radiant warmer only. Answer. B. Begin immediate positive pressure ventilation (PPV) with airway positioning and warming and prepare chest compressions if HR remains 60. Rationale. HR less than 100 and poor respiratory effort require immediate ventilation. HR less than 60 after 30 seconds of effective PPV requires chest compressions. Dry or warm and position airway concurrently. Option A. Delays life-saving support. Option C. CPAP is for spontaneously breathing infants with respiratory distress, not for an infant with HR 60 and limp. Option D. Suction or radiant warmer is secondary. Suction only if airway obstruction suspected. Follow NRP sequence. Airway, breathing, PPV, circulation compressions, drugs if needed. Question 27. A pregnant patient refuses recommended induction at 41 plus 2 weeks, citing desire for natural labor. What is your best midwifery response? A. Force the induction due to fetal risk. B. Respect the patient's autonomy. Provide evidence-based counseling regarding risks or benefits. Document informed refusal and offer continued surveillance options. C. Tell the patient she is irresponsible and discharge her. D. Ignore refusal and continue routine prenatal care without further discussion. Answer. B. Respect the patient's autonomy. Provide evidence-based counseling regarding risks or benefits. Document informed refusal and offer continued surveillance options. Rationale. Ethical midwifery practice honors autonomy. Provide clear informed consent or refusal information about risks of post-term pregnancy, oligohydramnios, stillbirth, alternatives, NST, AFI, induction when necessary. Attempt to negotiate a plan, and document counseling and the patient's decision. Option A violates autonomy and legal/ethical standards. Option C is disrespectful and unprofessional. Option D fails to ensure patient is informed and safe. Offer increased surveillance if declining induction. Question 28. A midwife suspects placenta accreta on ultrasound at 36 weeks in a woman with prior cesarean. What is the appropriate next step in care planning? A. Schedule vaginal birth at home with the midwife present. B. Refer for multidisciplinary planning, OB/GYN, anesthesia, blood bank, neonatal team, and arrange delivery at tertiary center with blood products available. C. Reassure the patient and schedule routine labor induction at local unit. D. Recommend immediate termination of pregnancy. Answer. B. Refer for multidisciplinary planning, OB/GYN, anesthesia, blood bank, neonatal team, and arrange delivery at tertiary center with blood products available. Rationale. Suspected accreta requires planned delivery in a center with surgical, transfusion, and neonatal capabilities. Multidisciplinary planning reduces morbidity or mortality. Option A is unsafe. Option C underestimates risk. Option D, termination, is not indicated without counseling and shared decision-making. Timing of delivery and surgical planning are primary. Question 29. During continuous electronic fetal monitoring, you notice sinusoidal pattern for several minutes in a preterm neonate. What does this suggest, and what should you do? A. Normal variability. Continue routine observation. B. Suggestive of fetal anemia or severe hypoxia. Notify team. Prepare for expedited delivery and neonatal resuscitation. C. Sign of maternal medication effect only. Stop monitoring. D. Artifact due to maternal movement. Reposition mother and ignore pattern. Answer. B. Suggestive of fetal anemia or severe hypoxia. Notify team. Prepare for expedited delivery and neonatal resuscitation. Rationale. A true sinusoidal pattern is concerning for fetal anemia, severe hypoxia, or fetal maternal hemorrhage and warrants urgent evaluation and likely expedited delivery and neonatal support. Option A is incorrect. Option C may be partially true for some drug effects, but cannot be assumed. Must act. Option D risks missing a life-threatening pattern. First, confirm tracing quality, but do not ignore. Question 30. A postpartum client 2 hours after vaginal birth shows tachycardia 120 bpm, pallor, and soaked perineal pad in 15 minutes. What is your priority action? A. Continue routine observations and document findings. B. Call for help, assess uterine tone, massage fundus, establish 2 large bore iverses, start fluid resuscitation, and prepare for blood transfusion if needed. C. Give oral iron and send home for rest. D. Offer analgesia and observe. Answer. B. Call for help, assess uterine tone, massage fundus, establish 2 large bore iverses, start fluid resuscitation, and prepare for blood transfusion if needed. Rationale. Signs indicate major postpartum hemorrhage. Immediate activation of hemorrhage protocol, fundal massage for atony, IV access and fluids, cross-match and prepare blood, and escalate to surgical management as needed. Option A delays life-saving treatment. Option C is inappropriate. Option D misses hemorrhage severity. Question 31. A woman in active labor with suspicious prolonged decelerations after epidural reports sudden hypotension. What is the most likely cause and next step? A. Uterine rupture. Immediately perform transvaginal ultrasound. B. Maternal supine hypotension from aortocaval compression. Turn patient to left lateral. Give IV fluids and increase vasopressor support as needed. C. Maternal anxiety. Offer reassurance only. D. Hypovolemia from blood loss. Place Foley catheter only. Answer. B. Maternal supine hypotension from aortocaval compression. Turn patient to left lateral. Give IV fluids and increase vasopressor support as needed. Rationale. Epidural can unmask maternal hypotension, and supine positioning causes aortocaval compression, leading to decreased uterine perfusion and fetal decelerations. Immediate repositioning left lateral, IV bolus, and vasopressors, ephedrine/phenylephrine per protocol. Restore perfusion. Option A is possible in severe cases, but classic initial action is repositioning or fluid. Option C is insufficient. Option D may be relevant if bleeding, but fundal assessment and repositioning are first. Question 32. A laboring woman has chorioamnionitis, suspected due to fever 38.5 degrees Celsius, tachycardia, and foul-smelling amniotic fluid. What immediate actions should the midwife take? A. Continue labor without changes. Antibiotics only if postpartum fever persists. B. Start broad-spectrum IV antibiotics, monitor maternal and fetal status, and plan for prompt delivery considering maternal and fetal risks. C. Immediately perform C-section for all chorioamnionitis cases. D. Withhold antibiotics and start tocolytics. Answer. B. Start broad-spectrum IV antibiotics, monitor maternal and fetal status, and plan for prompt delivery considering maternal and fetal risks. Rationale. Chorioamnionitis requires prompt IV antibiotics, for example, ampicillin plus gentamicin per local guidelines, maternal/fetal monitoring, and usually expedited delivery. Vaginal preferred if possible. Option A delays care. Option C is not required for all cases. Option D, tocolytics, is contraindicated in infection. Question 33. A woman requests home birth but has medical history of prior classical cesarean. What is the appropriate midwifery response? A. Honor request and plan home birth with emergency transfer plan. B. Counsel that prior classical cesarean is a contraindication to home birth due to risk of uterine rupture. Recommend hospital birth and document counseling. C. Agree only if she signs a waiver. D. Proceed with home birth if she has no current symptoms. Answer. B. Counsel that prior classical cesarean is a contraindication to home birth due to risk of uterine rupture. Recommend hospital birth and document counseling. Rationale: classical cesarean vertical uterine incision carries higher risk of rupture in trial of labor. A planned home birth is unsafe. Midwife should counsel, recommend hospital delivery with appropriate surgical backup, and document the discussion and patient preferences. Option A or D would put patient at risk. Option C, waiver, does not mitigate clinical risk. Referral to appropriate setting is required. Question 34. A cardiotocograph shows recurrent late decelerations with minimal variability despite intrauterine resuscitation. What is the correct disposition? A. Continue monitoring for several hours. B. Prepare for expedited delivery. Consult obstetrician for possible operative delivery. C. Reassure mother and attempt ambulation. D. Remove external monitor and rely on intermittent auscultation. Answer. B. Prepare for expedited delivery. Consult obstetrician for possible operative delivery. Rationale: recurrent late decelerations with minimal variability after resuscitation indicate ongoing uteroplacental insufficiency and possible fetal compromise. Expedited delivery, operative vaginal or cesarean depending on situation, is indicated. Option A risks fetal hypoxia. Option C is inappropriate. Option D removes continuous surveillance when fetus is non-reassuring. Question 35. A breastfeeding mother develops a firm, tender unilateral breast mass on day 6 postpartum with fever. What is your best management step? A. Recommend warm compresses, continue breastfeeding or pumping frequently, and start appropriate antibiotics if mastitis suspected. B. Stop breastfeeding permanently from affected breast only. C. Ignore and advise herbal remedies only. D. Immediate breast biopsy. Answer. A. Recommend warm compresses, continue breastfeeding or pumping frequently, and start appropriate antibiotics if mastitis suspected. Rationale: acute mastitis management includes continued emptying of breastfeeding or pumping, warm compresses, analgesia, and antibiotics for bacterial infection. Stopping breastfeeding can worsen engorgement and delay healing. Option C, inadequate. Option D, biopsy. Unnecessary acutely unless abscess suspected or mass persists beyond treatment. Question 36. A midwife is caring for a woman with suspected amniotic fluid embolism who is hypotensive and hypoxic. What immediate priorities should the midwife follow? A. Observe only and call anesthesiology if needed. B. Activate emergency response. Support airway/oxygenation. Optimize circulation with IV fluids or vasopressors, and prepare for urgent multidisciplinary resuscitation and delivery if maternal stabilization requires it. C. Give high-dose oxytocin bolus only. D. Administer tocolytics. Answer. B. Activate emergency response, support airway or oxygenation, optimize circulation with IV fluids or vasopressors, and prepare for urgent multidisciplinary resuscitation and delivery if maternal stabilization requires it. Rationale: amniotic fluid embolism is catastrophic and requires immediate ACLS-like resuscitation, high-flow oxygen, cardiovascular support, coagulopathy management, and multidisciplinary team, including anesthesia, obstetrics, and ICU. Option A delays care. Option C and D are inappropriate. Expedient delivery may be necessary to improve maternal resuscitation. Question 37. A 35-year-old with gestational diabetes on insulin has a non-reactive NST at 38 weeks. What is the next appropriate action? A. Reassure and repeat NST in 2 weeks. B. Perform biophysical profile BPP or contraction stress test and consider delivery planning depending on results. C. Stop insulin and schedule home glucose monitoring only. D. Immediate cesarean section without further assessment. Answer. B. Perform biophysical profile BPP or contraction stress test and consider delivery planning depending on results. Rationale. Non-reactive NST at term warrants further fetal assessment, BPP or CST, to determine fetal well-being. Decisions about delivery depend on these results. Option A delays evaluation at term. Option C is inappropriate management of GDM. Option D is premature without further testing. Question 38. A midwife suspects postpartum endometritis in a woman on day 3 postpartum with fever, uterine tenderness, and foul lochia. What is appropriate management? A. Start broad-spectrum IV antibiotics and supportive care. Consider hospital admission depending on severity. B. Advise acetaminophen only and discharge. C. Recommend immediate reoperation. D. Start high-dose corticosteroids. Answer. A. Start broad-spectrum IV antibiotics and supportive care. Consider hospital admission depending on severity. Rationale. Postpartum endometritis is treated with broad-spectrum antibiotics targeting polymicrobial flora, for example, clindamycin plus gentamicin or per local policy, analgesia, and hydration. Admission depends on severity. Option B insufficient. Option C not indicated unless complications. Option D inappropriate. Question 39. A midwife is asked to delegate a complex postpartum wound dressing for a woman with a 3rd-degree perineal tear. What is the correct action per scope and delegation principles? A. Delegate the task to an unlicensed assistant without supervision. B. Assess the competency of the delegatee, provide appropriate instruction and supervision, and retain accountability for delegation decision. C. Refuse to delegate and do nothing. D. Delegate verbally with no documentation. Answer. B. Assess the competency of the delegatee, provide appropriate instruction and supervision, and retain accountability for delegation decision. Rationale. Delegation requires assessing the task complexity, the competence of the person delegated to, providing clear instructions and supervision. The midwife retains overall accountability. Option A unsafe and violate scope. Option C is not constructive if safe delegation is appropriate. Option D fails to document and supervise. Question 40. A clinic policy change requires a midwife to adopt a new, evidence-based protocol for 3rd-stage management, active management. How should the midwife implement this change to ensure patient safety and interprofessional acceptance? A. Ignore the protocol and continue previous practice. B. Review the evidence, attend training, update written procedures, educate staff and patients, monitor outcomes, and participate in audit and feedback. C. Implement the protocol immediately without staff training. D. Adopt the protocol but stop documenting outcomes. Answer. B. Review the evidence, attend training, update written procedures, educate staff and patients, monitor outcomes, and participate in audit and feedback. Rationale. Implementing a new evidence-based protocol requires reviewing evidence, competency training, clear written policies, patient education, and monitoring to ensure safety and quality improvement. Option A resists best practice. Option C risks errors due to lack of training. Option D removes essential quality improvement measures. If you found this video helpful, don't forget to like, subscribe, and share with your fellow nursing students. Hit the bell icon so you never miss an update. See you in the next one. Happy studying.